Very good afternoon, everyone. I welcome all the participants and our guest speaker, Professor Dr. Kamlesh Mehta, sir, Satva Charitable Sanstha and Satva Homeopathy extends a great and warm welcome to all the participants. And we are glad that on Sunday afternoon, all of you have gathered to collect the knowledge which would be given by a very senior Professor Dr. Kamlesh Mehta, sir. So before we start, I would like to give a brief introduction. Professor Dr. Kamlesh Mehta, sir, as we all know, he was the head of the department, Repertory and Case Taking, and he was a very senior professor in the college at CMPH Medical College. Currently, he is a Dean Academics and PG Director at Naiminath Homeopathic Medical College, Agra. He is a founder and facilitator for Hahnemannian Gurukul group, which is basically focusing on application of Hahnemannian concepts and fundamentals to the practice through the program of getting back to roots. So getting back to roots, it's a very important concept which sir has initiated. He is also a physician at Homeopathic Panacea clinics, and he is a CCH teacher of teachers orientation training programs. He has conducted a lot of training programs for teachers all over Maharashtra and all over India. He is also examiner at Durban University of Technology, Homeopathic section, which is in South Africa. He is a member of Syllabus Committee at National Commission of Homeopathy, New Delhi. As we all know, it is one of the prestigious government organization. And also he is attached to the Maharashtra University of Health Science. He is also the chairman and ethical committee for homeopathic pathogenetic trials of International Academy of Advanced Homeopathy, and the other song, which is headed by one of the most popular homeopathic physician, Dr. Rajan Sankaran sir, retired as I had already mentioned as a head of the department from CMPH Medical College in the Department of Repertory and Case Taking. Now, as I discussed with sir before we started this concept of taking up a webinar, sir has a very important and a noble thought that it is not about teaching, it is about teaching and learning and evolving together. So today's webinar is focusing around an interactive learning. So sir believes in interacting learning and solving grassroots problems which each and every homeopathic doctor faces, right from the beginner to the senior most level. So considering this particular concept, we had floated an idea that we should ask for the questions from all the participants, and based on these questions we can mount the discussion and evolve together and build on the interaction, and eventually the group will grow in knowledge together. So I welcome you, sir, and it is nice to I have been sir's student all throughout, and still it's an opportunity and a privilege for me to learn from you, sir. So sir, it was a fabulous response as suggested by you. Your concept worked out, and we received multiple questions. I would just which is covering a lot of sections of case taking, case taking, case receiving. Some questions were related to, sir, scope of homeopathy, and with which cases to be accepted, which cases should not be taken up by a homeopath. There were certain questions related to how do we address CNS disorders, some cases related to, various pathologies, how a homeopathic doctor should address to it, and various questions related to posology and potency. So I would like to share the screen regarding the questions, and so that it is visible. So is it okay if I share the screen, sir?
Yes.
So is my screen visible?
Yes.
So as beautifully seen in this slide, there are a rainbow of questions related to various scope of homeopathy, prognosis in CNS, case taking, repertory versus approaches, selection of repertory, selection of symptoms, selection of rubrics, repertorization, remedy selection, and posology. So these are the various categories under which the questions have been classified. So we would address as much as possible, and I hope all the participants who have raised these questions are with us. So first section is scope of homeopathy. So here the question which has come from the audience is scope of homeopathy in pathological cases, in difficult cases, which is related to various pathology related to CNS, CVS, liver, respiratory system. So how do we handle it? So can you just guide us with this?
Hello everybody. This is my privilege to be with Satva. I'm just wondering why am I getting info? Yarish, can you help me?
Yes, sir.
Why am I getting it? Hello. Okay. Yeah. Excuse me for the interruption. It is my privilege to be with Satva today, and Satva has done a lot of good works in these 10 years, and I suppose today is 13th free webinar organized by Satva, and this webinar will be one of its kind which is going to be interactive with participants, and we aim to mutual learning. We grow together, we develop fellowship. Now here the questions are coming to us from the participants. This is something very important and a great thing that participants are involving themselves actively in the webinar. So this is going to be not a passive webinar, and whatever we are going to talk, all of us interact, that I understand that these questions are coming from the practice. These questions are coming because we are actively participating in the learning in our colleges and from our patients. So questions are not theoretical. So obviously answers are not going to be theoretical. The answers that are from our literature, and maybe somewhere some of my experiences which I put across. Now, in homeopathy, we know that nothing is theoretical. It has begun from the experimental science, and it has gone to the experiences, and all these experiences and the outcome, the results are recorded in our literature in the form of aphorisms or in form of lesser writings, in forms of mathematics. So everything that we are going to discuss that is emerging from the practice. Though it gives us the sound base of the rules, it gives us the idea how we are supposed to act subsequently. So it sounds theoretical. But if you understand this is the resultant, the outcome, and then we interact on that, then it will be very interesting webinar. The question number 1, that is with regards to scope. Every physician, when come across any case, the first question is in the mind of a patient as well as in the mind of the physician is whether homeopathy or whether a homeopath will be able to do his best in the case. Because the purpose of the patient is to get rid of the problem and our purpose is to cure the case. So this is the foremost important thing when we come across any case, and obviously patient is much more bothered when there is a pathological problem. For cold and cough, they have already managed somewhere outside. Unless there is very recurring and troubling, then patient come to us. So the scope of homeopathy in difficult cases. Now the point is, when does case become difficult? So case becomes easy when we have sufficient tools and knowledge to combat the condition. So that is what exactly that aphorism number 3 that comes into the play. That we have to understand disease, not just its pathology, but its disease, not at ease state of the patient. And from there, we travel to what is to be treated in every individual case. This is something very important. That every patient comes to us, patient may come with some name of the nosological name. Behind that nosological name, we know the process of the pathology and we expect certain symptomatology. But as a homeopath, my one step is ahead that what is to be treated in this patient, the patient who has come and consulting me. I don't have to bother about the 1,000 cases which are there approaching with pneumonia. I have to see what am I supposed to treat in this pneumonia case. So in that, what are the distinguishing features or the features which are defining this case which will help me to come to the remedy that I am going to prescribe. That is what exactly Dr. Hahnemann told. Don't go by the name of the disease. Name of the disease may go on changing. But what is required for a homeopath that he mentions in aphorism number 6? That is one, there is deviation. Then second, the course of the disease or morbid phenomenon. Then third, indications and accidents, and not to forget about the causations. So we as a homeopath, we focus mainly on these particular aspects rather than just name of the disease. We have to focus the disease in the patient. Whether that picture is clear, what is to be treated, then possible that I can treat. Because I am not going to treat just by the name. Like, okay, it is a cardiac disease, so I give Crataegus, or it is a cardiac disease, so I give Digitalis, or it is a cardiac disease. I don't do that. I may think about its affinity and sphere of effect. And so our therapeutics that we have learned, that will come to our rescue. But that is not the final verdict. This is what Dr. Herring tells us. Dr. Herring has mentioned beautifully in Borik's Mathematica and Repertory preface that the name of the disease should not become the criteria to decide a remedy. It only helps us to understand that these many drugs have the capacity to cure such symptom or such condition. And every drug listed thereby will have their own picture of the disease. And the same thing Dr. Nair mentions under the preface of Herring's Guiding Symptom, that the theta which is written in between the symptom and the clinical condition should not make physician to determine that this remedy is only for such clinical condition. That only implies that that remedy has a capacity to cure such clinical condition provided this symptom is present. And likewise, it can cure any other condition if this symptom is present. So that is why it is very much essential to understand whether it is a cardiac pathology or liver pathology or renal pathology or brain pathology, likewise the CNS cases. So whatever are the conditions, we have to first understand what is to be treated. Is it within the capacity to be cured? Is it reversible? We have to understand all these things from the course of the disease. Dr. Boger has very beautifully written, isn't it, in his foreword of Boger Synoptic Key? We have to understand cause and course of the disease. So if you focus on that, then for homeopath, sky is the limit. Or if I don't understand the case, then I have no role to play. I refer to other people who can understand this condition, maybe homeopath or any other mode of therapeutical physicians. So I suppose this gives answer. Who had asked this question? Is he present here? So Priyal, it is a very nice question to begin with, because without having knowing the scope, we should not just run blindly that patient has come and let me just start. No. Give a thought, recall your medical knowledge, recall your general knowledge, recall your every other specific knowledge and understand. Okay, so Dr. Yavi, presenting the report.
Yes, sir.
Okay, Priyal, so answer your questions. Now Priyal is coming to the real question.
Yeah.
But echo is still persisting, Yarish.
Priyal, you can directly ask the question. It is okay. You can ask the question.
Yes, that is a good point. Priyal, come on. Let us make it interactive.
Yes, sir. Yes, sir. I just wanted to ask you, if it is emergency or if it is major structural change, जैसे कि in cirrhosis of liver and all, so sir, we can revert that.
Okay, what do you think about it? Can it be reverted?
Isn't it difficult?
It may be difficult, right? We know liver is one structure which has the ability to regenerate. Now the point is about the tissues which are already fired up, where fibrosis has taken up. So obviously these tissues cannot be regenerated. These tissues cannot be replaced, isn't it? Whether it is in the lungs, whether it is in the liver, whether it is in the heart, whether it is in the brain. Infarction, it can be compensated, but it cannot be reversed. So it all depends upon every patient who's, say it is autoimmune cirrhosis of liver. So our target is to correct the autoimmunity, so that further damage can be prevented, or the prevention of the autoimmune aspects on other tissues. So that is our target. Now the point is of emergency. Emergency means where person is having the problem at the last phase of his life. Then that is an emergency, right? And when we are at the point of the emergency, obviously, whatever is the state of the patient, our observation, that plays a major role. And at that point of time, UB, Dr. Boni Hussain has given UB, the what is affected. And very quickly we have to get what is affected, why is it affected, what are the peculiarity of it, how it does it affect the person. But this has to be done very, very quickly because you are observing. That is why we have certain remedies like corpse reviver. Which are the corpse reviver, Priyal?
Sir, Carboveg?
Very good. Carbovage, arsenic alb, camphor, veratrum. So all these drugs are corpse reviver, right? So at such point of time, the first point is to save life of the patient. And then you think about what is to be done next. Because when, at such conditions, usually we face one-sided disease. Because picture will not be so clear. So with that best of your ability, you act. And sometimes it may be necessary to integrate your therapy with other kind of the therapies where their action is straight physiological. And thus, we have to revive the patient. Is that clear, Priya?
Yes, sir. And sir, I wanted to ask that in like in major, as we have told that in major like structural diseases and end stage diseases, we don't have to use the higher potency. So, sir, if killers act, it can also cause the killers aggravation. So, what kind of potency or we can give?
The first point is when it is a heavy structural damage. So when we say it is a structural damage, again the point comes up, is it reversible or irreversible? So what is your problem definition and what is your aim of resolving the problem? Are you palliating or are you curing or you are relieving patient from the death pains? So when you are very clear of your therapeutic aid, help to the patient, then you will proceed accordingly. Now the point comes about posology. We know that a simple rule has been given by Dr. Hahnemann in aphorism number 26 that weaker dynamic affection is extinguished by the stronger one, provided it is similar of its kind. Now we have to apply that rule. Now patient is in the stage of the curability. Then you will definitely assess every possible aspect of the morbid phenomenon, its characteristics, causations, and find out the ability of the patient to meet the demands to have a cure. So your posology will depend upon the strength of the disease as per aphorism number 26. But when your job is only to palliate, only to give a supportive line of treatment, then obviously you are not over enthusiastic to cure the case. The killer aggravation that is mentioned by Dr. Dhaule, thereby he has really very much mentioned that in incurable cases, when physician is over enthusiasm and prescribing remedies unnecessarily, then will create a problem because you are inducing a disease in the weaker system. So it is not with regards to that. Okay. So here the wisdom is very important, that what is your purpose of treating the case. Okay, Priyal?
Yes, sir.
Does that help you?
Yes, sir. Sir, yes, sir. Thank you, sir. I also wanted to ask one question that in cardiac cases, like मतलब normal जैसे bone अगर diseases हो, तो वो chronic होते हैं sir. But in cardiac diseases we would require the quick prescription or a quick recovery. So sir, how to go about in that cases?
Obviously, aphorism number 3, your knowledge is your experience, your practice, your skill, and your ability to observe. And last but not least, to integrate the things.
So sir, we have to use the integrated approach in all that diseases,
No,
right?
I say to integrate your observation with clinical history, with characteristic symptoms, with causation, deviation, and your observation which is right in front of you. And then integrated approach, homeopathy is other therapy that will depend upon the call of the time. If you find yourself lacking, if you are not able to do it, or you think that you can't waste time, and patient immediately requires other physiological doses, then you have to just go ahead with that.
Yes sir, understood. Thank you sir.
Okay, Priyal. I hope
There are
this
more
kind
questions in the chat box.
Okay, we'll go with that. The point is that whether such discussion is helping the group, the participants give us feedback so that we know that whether we continue with such discussions or... Okay. Because rather than adding new things, or my case is more than that is you remained with clarity about your unanswered questions. And these are all frequently asked questions in all the groups, wherever I attend. Most of the questions are similar kind. It means this is the usual aspects which we require to deal. It means that is going to help us in our practice very much. And no question is foolish, no question is silly. जैसे हर एक फ्रेंड जरूरी होता है, उसी तरह से हर एक सवाल जरूरी होता है, और हर सवाल एक जवाब को ढूंढता है, और वो जवाब एक नया सवाल को जन्म देता है. So that is why we have a lot of other questions now. What are the other questions, Dr. Rakesh? Are there any relevant questions, or we go to the slide questions? Okay, we can...
Hello. Sir. Certain questions are there. One of the question which has been asked by Dr. Sadhna,
Okay.
She has asked a question that if a patient is in multi-organ dysfunction or multi-organ failure and admitted in ICU, how do we approach such cases?
I think partly I have already answered that, Sadhna, whether you have answer.
Yes, sir. Yes, sir.
Thank you very much. And Dr.
Somewhat
Dr.
there is
Yadesh,
lot of
please deal
echo.
with the echo again. Yeah, Dr. Sadhna, please go ahead.
Thank you, sir. Sir, actually, I understood some of the part of this question, like whatever you answered. The thing was like in such cases, if patient is like in multi-organ failure and all such like worst cases, so that time there are a lot of medications which is also going on. So when we go ahead with the integrated approach, so the allopathic medicines or the other medicines, they may also add on to the symptoms or the picture of the disease, right? So then it becomes a bit difficult, like how to go about in such cases.
It
Because
is
those
very
medicines will also...
Very practical question, Sadhna.
Thank you, sir.
See, and for that, Dr. Hahnemannian has already come to your rescue. Aphorism
Yes.
92. Aphorism number 91 says that when patient is on various other therapeutic measures, you wait till you get original unmodified picture. But if patient is in crisis and you can't wait for that picture to emerge, then you consider this as a complex disease. It means original disease and now newly evolved or iatrogenic disease that is combined, and now very quickly you apply your knowledge. Now the what to do, how to do, for that you have to have preparation by study of the Material America, therapeutics, repertories and disease conditions, and I'm sure teachers are always helping students, guiding about it as and when it is possible. So we have to bring those things immediately. All these 12 subjects which we are learning, that has to come together at one point of time, and then we find out a solution with the integrated learning. Okay, Sadhna?
Yes, sir.
And most of the time these are one-sided disease. So what
Yes,
one-sided disease has given the idea is immediately form the totality, what are remedies found out, you give that remedy, then again evaluate, form the totality and see what is the next action, right?
Yes, sir.
Because your only
Thank you,
purpose
sir.
is to save life, not cure at that point of time.
Yes, sir, right.
Or ease out the death. Always we are not God, always we cannot cure or we cannot save life. But we can make the life very easy to the end point of the death.
Yes, sir. Thank you, sir.
Okay. Yeah, Dr. Rakesh, next question.
So up till now, I think it is very clear to the group that we have to understand the evolution of the disease and understand whether it is within the scope, whether the pathology can be tackled or it can be cured or it can be, just given as a palliation. So what Sadhna had asked, what sir has beautifully explained that, we should go by layer in cases which are of a more complex dimension. So the another question which was asked by Dr. Meenal, she wants to know that till what time we should wait in an acute disease. If you have a prescription, you're prescribed. After your first prescription, till how much time we should wait and come to a conclusion whether our medicine is acting or not acting?
Why will we wait? When we know acute disease by itself can be threatening to life. So it will all depend upon the strength of the disease, threshold of the patient, immunity condition of the patient. All these things we have to take immediate action based on that. Now your point is, your question is implying to understand how much does it take for a remedy to act in acute disease? If I understand your question in that way, am I right?
Yes, Dr. Meenal, sir has understood your question correctly.
Yes, sir.
Yes.
If remedy is right, the action is immediately. It can be few seconds to few minutes. The point is, symptomatology may persist because symptoms are evolving because of underlying pathology, virology, or sepsis. What may be the reasons within? But patient's general state, his activity, his state of drowsiness, or if he has not drank water or ate something, patient may just ask for water. There is a change in his general state, and that has to occur immediately. So many times, or most of the time nowadays in the clinic, when patient comes and we give olfaction to the patient, even in our OPDs that we have done very frequently, we give olfaction to the patient, and immediately patient is assessed within 5 to 10 minutes what are the changes patient is finding. So patient says, my headache is still there, but it is not bothering me to that extent, or it is not hurting. Or patient says, I still feel like lying down, but I am not so drowsy. So there is a change that comes up. If that change comes up, obviously the underlying structural changes or pathological changes are going to take time to repair. itself. So we have to first assess the general improvement coming up in the case. And then second point comes up, the symptomatology in that general symptoms and then specific particular symptoms. Okay?
Okay, sir. Thank you. So one more question. So mostly when the patient comes to us in acute stage, it is mostly happen that the state of the person changes continuously. The picture of the symptom changes. So how frequently we can change the medicine?
Minal, you have addressed a very, very, very essential question, which we all come across very, very frequently. And for that, Dr. Boger has come to your rescue. Boger's synoptic key in the foreword, he writes that symptoms goes on changing very frequently, but dyscrasia do not. Are you getting my point?
No, sir. Can you please explain it again?
Symptoms can go on changing. This symptoms goes on evolving. As the pathology evolves, the symptom has to express the underlying pathological process, right?
Yes.
So its form may change, its intensity may change, its presentation may change. So symptoms evolves in the acute condition with the progress of the disease. And now you know that progress is fast. So change will be proportionate to that. It will be fast, isn't it?
Yes, sir.
And that will also depend upon the patient's threshold that is within. How patient is fighting. Because patient is fighting, and suddenly he gives way. Very beautifully, Boger in his synoptic key is writing about phosphorus. Just a moment, I'll take out phosphorus for you. Active metabolism, rapid growth, insidious onset, gradually increasing debility, ending in severe or rapid disease. See how things are changing, Minal,
Rapidly.
right? And the remedy
Yes.
is one, phosphorus only. But the picture
Yes.
is changing because internally the process is changing. And if process is changing, the things are, at this point of time, there is active metabolism and there is a rapid evolution, and suddenly we find there is a increasing debility and ending in severe or rapid disease. See, both things occurring in the same patient at a different point of time in
Okay.
the phase of the evolution.
Yes, sir.
So that is what Dr. Boger says, that form will go on changing. The symptoms may go on changing because that is the only expression of the internal derangement. So derangement is occurring at a particular speed, it is occurring in a particular pattern, it is occurring in a particular way. So the symptoms will go on changing. But dyscrasia will not. It means the tendencies will remain same. Pneumonia is going to remain pneumonia. But in which phase of the pneumonia, accordingly, the symptoms will be different. If it is in the phase of the catarrhal phase, if it is in the hepatitis phase, if it is a hepatization phase or inflammatory condition. So, are you now getting my point?
Yes, sir. Yes, sir.
The symptoms will differ, but the process will not. And this process is occurring in the same patient, but the time may be different. So the disposition tendencies don't go on changing so fast. So in every such conditions, we have to focus on the disposition of the patient.
Okay, sir.
Disposition of the patient. That is why generals and concomitants are very helpful in the case. Is this clear?
Yes, sir. Thank you very much.
I must thank you. You brought out such a beautiful question, Minal. Very nice, very nice.
Thank you, sir.
Okay. I hope this is helping. And Dr. Yarisha to help me about my echo. Thank you.
Yeah, sir, it is helping. I think personally, I'm really going back to my roots. So it is really helpful. And sir, another question which was sent by Dr. Shriya Kinariwala, she said that which type of therapy other than homeopathy, not necessarily allopathy, should be introduced during the course of the disease. So how do we come to know about this? Okay, whether this point of time we have to use this kind of therapy during the course of the disease. What are the indications for that?
This is something very important, that we require to give support to the patient other than remedial measures. And this Dr. Hahnemann has written very beautifully towards the end part of his organon. So all these supportive line of treatment, exercise, hydration, and diet and regimen, and the circumstantial accessory things that is mentioned in aphorism number 5. Way of living, diet, occupation, relationship, sexuality, all these aspects we require to explore and give support to the patient as there where it is required to have the correction. Yes, Dr. Kinaliwala, does that help you? Or you have...
She agrees, sir. She agrees.
Okay, thank you. Thank you very much. And this we are discussing nothing is hypothetical, nothing is theoretical. These are all that we are, and those who are practicing at the bedside and in the hospital, IPD, they must be experiencing all such things.
Yes, sir. I personally vibrate with the concept of what evolution of the disease. Recently, I was treating a case of, initially it presented with URTI, then it landed with LRTI, and then the patient was febrile. Eventually, the drugs which were coming from right from the superficial, from initially Aconite was given, then eventually Kalika turned out as the disease progressed, and then the patient was not better, and then eventually when the totality was clear, then the antimony tart did the benefit to the patient. So as we have seen, sir, personally, I mean, I'm practicing in IPD. So what I have seen that when the patient comes to initial first or second day of the illness, the picture is different. But and we give a medicine, and if the medicine is similimum, we often block the progress of the disease to a deeper extent. So that is what was my experience.
Okay, that is great. We have to keep all these points in mind. Okay, we go to the next question. I'm really enjoying this session, and I'm meeting all the associates after so long. I'm loving you all. I love to see you back. My alma mater, CMP Homeopathic Medical students and teachers and my associates from various other colleges. Even Dr. Kamlesh Mehta from Dr. Pankaj Lakhani came from Surat. And Dr. Pankaj Lakhani has also got his own hospital. So I'm sure all such experiences he also must be seeing in his practice. Okay, we go to the next one.
So the next question which was asked is what is the role of homeopathy in infectious diseases? As we have all witnessed a very major infectious disease, a pandemic of COVID. So I think, sir, can you just guide us with this?
Very clear guidelines are given by Dr. Hahnemann. First of all, we have to understand the pure acute disease. We should not misunderstand it with acute exacerbation of chronic disease. So acute disease is, as theoretical we know that it is outburst of latent sora. But that is very important, that is true, because that is connected with our fundamental cause. We are affected, there is a fundamental we are affected, hereditary factors are there, the soil is prepared, and on top of that some exciting factor that comes up and awakens our sora which is otherwise dormant, latent, sleeping. So when it is awakened from the sleeping condition, it will have all the agitation and its violence and the rapid. What happens when we are suddenly awakened from our sleep in the morning or in the middle of the night? So that is what activity is there. Now this activity we require to really, in real sense, we have to deal with it. Otherwise it can end up in the death. So he has suggested very simple things. Is it a individual disease, sporadic disease, or it is epidemic disease? Now, for example, I am purely talking from homeopathic point of view. COVID, as Dr. Rakesh brought out the point of the COVID, a very recent experience with us. It has been taken as an epidemic. But if we see, it was affecting certain group of people in certain places, not all which are getting affected. So it was more of a sporadic disease. And obviously we have to observe all these groups differently. And in every group we have to see every person differently. And then we can derive certain group of the drugs for that particular population, for that particular people who are affected in that area. I would suggest a group, if they are really very much interested, then there is one video on my YouTube channel. At that time, it was not very much allowed to talk words COVID. So this entire experience has been reported and compiled with statistics. There is a flu-like disease and homeopathic management, something like that is the title. So I suggest everybody to just go through that small video of 20 minutes, whereby I have given statistics of 20 patients. And there the point is that all the 20 patients, out of almost 17 or 18 patients, they required different remedies, and which happened to be the remedy which they were receiving. So it was the dispositional remedy itself was helping. In one case, the dispositional remedy did not work, and that was tested that I am not the right remedy. And the review had to be taken and the action was corrected. So this is what is that if the disposition, as we had seen earlier in the question, that dyscrasia remains same, symptoms may change. So we focus on the disposition of the patient. The same disposition is giving rise to this plethora of symptoms. So we have to deal with, we don't have to forget this unless the disease is so powerful that it overpowers the disposition and it gives its own picture. But that is not so common. Most of the time, patient starts fighting and responding from its disposition level. And then we see the disease evolving. Suddenly patient don't go into such crisis. It evolves into crisis. And so that remedy will majorly, even now there are plenty of cases coming up. Suddenly there is a eruption of fever. There are COVID cases also coming up. And in that, our experience is, if our remedy, dispositional remedy is tested at that time, if it is not giving result, it is not right remedy. But then we have to go using concordance or collateral relationship as mentioned by Dr. Nair. And we have to correct our prescription till the time we understand that this is correcting the patient. Does that answer the question, how to combat infectious disease?
Yes, sir.
Okay.
So we go with
There are about 20 questions. And let us see if we can meet with them, because we have done 3-4 questions in 1 hour. So go ahead.
yeah.
And participants, we will stop anytime whenever you say this is enough, then we will stop and we can continue in subsequent any other webinar. Okay. So not to hurry up, but understand every question, and understanding the question, we go to the answer of that. Okay. Yes, Dr. Rakesh, go ahead.
Hello.
Yes.
Yeah, I got disconnected. Sorry. So the another question was, you can hear me, sir?
Yes, you can start your slides also if you wish.
Yeah. So it was regarding how do we approach genetic and disorders, genetic and lifestyle disorders.
Oh boy, so there is a question for the world in general. Genetic, that we have understood totally in the different way 250 years ago. And that is why fundamental miasm, fundamental cause and theory of miasm evolved. So he was the person who connected that what we are is not independent of us, it is dependent on our parents or our hereditary tree. This sounds theoretical, but when we see that in practice, I am somewhere like my father, somewhere like my mother, but I am having my own chemistry and I have my own entity and my own individuality. I am not my I am not my father, I am not my mother, but I am of my own. This is very much there. In remedies also we see calcarea phos, there are features of calcarea, there are features of phosphorus, but calcarea phos is entity by itself. It has own distinguishing features from calcarea and phosphorus. So that is what is the scenario of the genetic disorder. Some defect, the manufacturing problem that is occurred. This now the situation is such that we can identify such genetic and anomalies right when patient is in uterus. So in the developing phase itself, it can be identified. So now if it has to be identified, obviously if it is a structural damage, it cannot be corrected. If it is a cleft palate, I cannot correct the cleft palate. But I understand that person is having the general anomaly like cleft palate or ASD, VSD, any other anomaly that is coming out. So I know that there is structure is not sound. I understand that there is a disharmony in the system going on, right from the genetic its manufacturing time itself. So that requires to be corrected. Whatever is possible to be corrected, that can be corrected. But otherwise, one has to live with it, but we don't leave the patient. We help patient to have the better life. Now, I recall certain cases like hemophilia, and that patient was having a very severe, now we have the different mild, moderate and severe. So there were two brothers. One brother was having the moderate hemophilia in the point that he had developed arthropathy, also contractures, and there were swellings around the joints. But even then he was able to move around and do his work. He was a contractor, construction contractor. So he had to go up to 4th floor, 5th floor. He used to carry Gamela. He used to work by himself to save money. But he was doing with his all disability. His brother was having a severe type of hemophilia, and he required the factor very frequently. Now, these patients, I could help them. When the severe one had to go for a tooth extraction, and though the factor was kept ready, but with the medicine, he could undergo the procedure, and he did not require that many factors which they expected to give. Likewise, the one who was having the contractures, now the first one, which I said about severe one, he did not continue and take treatment for a long period of time. But the other one, he came regularly for about 1.5 years or so for the treatment because of financial reason, without informing, because of his own shyness, he stopped the treatment. But in his case, we could see that arthritis and hematological collections, that was much under control. He continued to have that much hard work. He continued to run, he continued to climb, he continued to do all the exercises, exertional work. But he did not continue to get same kind of arthropathy and swelling. So that is how we have certain role to play where we can bring the changes. Now, whatever is mechanical is mechanical. Whatever can be corrected can be corrected. We have to keep these things in mind. In lifestyle disorders, obviously, lifestyle has to be corrected. Lifestyle has to be explored. It is innate or acquired. We require to understand. Most of the lifestyle we acquire to ease out our discomfort, to remain in the comfortable zone. We make habit of certain things because we want to be that way very comfortable. So whether it is innate or acquired, that we have to understand, and we have to deal that thing accordingly. This is very, very, very essential to correct lifestyle problems. Otherwise, aphorism number 4 will not be achieved. What is aphorism number 4 is? Preserver of health, prevention of further problems. And so, aphorism number 5, accessory circumstances, which is again mentioned in aphorism number 7. that we require to take note of accessory circumstances when we make totality of symptoms. And obviously, in aphorism 5, Dr. Hahnemann writes about fundamental cause. And in most of the time, it is miasm. In most of the cases, it is miasm. So he also says that not in all the cases it is miasm. But most of the genetic disease will be miasmatic conditions. And about that, pregnancy history is very much essential to treat such cases when they are in utero or they are outside. See how beautiful Dr. Hahnemann has written that give antisoric remedies when lady is pregnant to deal with miasms which is being developed in the embryo. So this is what little bit I understand and know about how to deal with genetic and lifestyle disorders. If anybody else has any experience, can share here. So does it helpful to the participant? Hello?
Yes, sir.
Okay, Priya. So we go ahead for the next question.
Sir, I wanted to
Yes.
ask.
Mm-hmm.
Sir, if for example, if the one parent is diabetic and there is 50% percent chance of the child being diabetic, so
Okay.
sir, can we prevent that? Matlab, can we prevent it with our medicine?
Of course, you can prevent, but provided he is ready to change his accessory circumstances, then you can make the process slower. Because accessory circumstances are like fuel to the fire. It will expedite the process.
Okay, sir.
So we go on next question. What is the prognosis when the patient is on homeopathic treatment in CNS cases?
I
So I
think
think it's a very general question.
we have already done that. Okay, next.
Now the next section is on questions related to case taking. Case taking, perceiving deviation in the mental health. How to take mentals.
How do you understand mentals of any person? How many of us are ready to allow me to dive into their mind?
Very few.
Very rare.
Sorry?
Very few.
Very few. None. Why they would want anybody to go into the personal life and the personal space? So here the point is about we have to focus on the deviation. And the deviation, the main aspect is of any mental aspect, whether in the health or in the disease, is known through the facial expressions, gestures, the language, reaction, and person's cooperation and coordination. Isn't it? That is why Dr. Hahnemann has written in necessary circumstances, moral and behavior. What is the exact word? Moral and see, we have all the answers in our book because he has revised it for 6 times. Moral and intellectual character. Moral and intellectual character. These things are very much active when one is interacting or one is defending and making life for his survival. So how to take mentals? Don't take mentals. Patient gives mentals. If you have paper and pen, please write down this. Don't take mentals. Patient gives mentals. Patient gives mental state, his perception, his behavior, his expressions are right in front of us. How person is describing his chief complaint. Patient has come. So patient is interested in narrating his problems. So now he doesn't know that you want a problem exploration to the level of every problems, the core of the problem. Patient has been trained to go to the doctor and say, you treat my constipation, you treat my headache, you treat my pains, you treat my heart problem, you treat my hypertension. So that is how patient is trained to go to doctors. So the same way patient is going to come to you narrating, doctor, please treat my psoriasis. Please, doctor, please help me for my IBS. Or child is brought that is having a high fever. So now here, how patient is talking and using his words for narrating his problem. And our ears are to be how this problem is troubling the problem, patient. I repeat again, how the problem is a problem for the patient. How the problem is troubling the patient. Or how patient intend to react back to that problem. Am I clear? Hello.
Yes, sir.
So mind
Yes, sir, it is clear.
mind is nowhere anywhere outside. Mind is very much there in whatever is talking. And then through that we go on making the boundary. And then we ask patient, you tell me how all these problems together really bother you. So patient says, I really feel hopeless, I feel frustrated. Doctor, I feel there has to be some solution to this. Doctor, what to do? I have to just live with this. There are so many responses that will come, which you tell patient to explain. Patient narrates it. And then you say, is this the same way usually you deal with all the problems you come across in your life? Or since when you have started taking up such stand? So once we start talking, then patients will open up because he has not got anybody to interact so far. Nobody was interested in him. People were only interested in his aches and fever and his problems. So when he gets someone to talk, because everybody wants to talk, everybody wants to say, मैं कहूँगा ना कि आज मैंने शिखन पूरी खाया तो आप तुरंत बोलेंगे अरे ऐसा क्या आज तो मैंने चाइनीज खाया मैंने आपको पूछा नहीं चाइनीज खाया कि नहीं but everybody wants to give their bit of things and patient also wants if you have a hearing ears if you have eyes which see if you show concern and you express only one thing, my sole purpose is to help you to have a cure. If patient finds that I am unnecessarily invading in his personal space, unnecessarily I am asking things. Yeah, though I am opening up the buried matter, then there is a aggravating factor for the patient. Don't do it. Hahnemann says in aphorism number 84, allow patient to detail his story. The same is given by Dr. Boger. Tell him to narrate his story. And from the story itself, you connect dots and make the picture. So patient will help you to connect dots. But don't add new dots by yourself. हम डायरेक्टली सवाल पूछने लगते हैं ना, आपको गुस्सा आता है क्या? Don't do that. Automatically things will open up, and if there is any deviation in the mental, or if you understand mind and disposition from the picture, it becomes very clear. Does it help you all, or you want any further clarification?
Yes, sir. It is helpful.
Okay, so we go to the next question.
Yes, sir. The next question is case taking and processing time management. How to manage time before patients with case taking and repertorization?
So many times we have embarrassment to refer books in front of the patient, or to refer your computer or work on the case. Never mind about it. If patient finds that you are working and you are really diligent to help the patient, he is going to appreciate it. So don't bother yourself कि patient के सामने कैसे करेंगे. And for case taking, our purpose is to find out the problem of the patient, which may be taken or done in 20 to 30 or 40 minutes, or it may take up 2 days, not only 2 hours. It is all how we are going into and how are we reaching to the core of the problem. Case is done, moment I say I have understood. But that is the main problem. How can I understand? Because he has a problem, he can only explain. He has to make me to understand. I cannot understand. If we take up this particular aspect, that is why Hahnemann has said, you become unprejudiced observer. Patient says, I have pneumonia. Oh, I know pneumonia. Okay, antimalarial is the best remedy for you. Then I don't know pneumonia of the patient who has sat in front of me. So I have to be unprejudiced without any prior judgment, because patient only knows what is the problem. So with that, if we proceed with the case, it is point is don't waste your time drawing the peripheral things or drawing new dots in the case. First see the dots that patient has given to you. You help patient to connect the dots. Patient says I'm having hypertension. Patient says I'm having the tendency to get angry. Then our job is to connect these two dots. What is the effect of hypertension on anger or anger on the hypertension? So likewise, we connect all the dots. That will help us to make totality. Totality is not difficult. Essential aspect of the case, we take and we connect dots that will help us to make totality. And if you really want to learn how I have learned to make totality. One case of therapeutic pocketbook in the original preface given by Dr. Bonihusen himself. And expressions written by Dr. Herring in his Herring's Guiding Symptom in the paragraph form. Every paragraph and the description of the fever or description of the pain, that is one single case of that remedy. You don't need to go anywhere out, hypothetical images, imaginary things, fanciful ideas. No. Herring's Guiding Symptom, every paragraph is one case, considered that way. So, if we are utilizing our time, then it is not time wastage, but it was time invested. Okay. Does it help the participant? Hello? Whose question was it? Hello, am I audible?
Yes, sir.
Okay. Okay, Punit Rana and Zinal Thakur. Thank you. We go to the next question.
Case taking, assessing intensity of symptoms. So this is one difficult thing, and it's a challenge. How do we ascertain the intensity so that we can classify it into a zone of more characteristic?
How am I understanding your intense urge for learning? We are almost about to complete 1.5 hours, but still you are there. Today is Sunday, but even then you are there. So intensity of the symptom is understood from the narration of the patient, expression of the patient, and observers' observations. That includes you as well as the attendant. So whatever is there in front of you, you combine everything, and then you can understand what is the intensity of the symptom. Does that give answer to the question?
Hello, sir.
Yeah, Ujjwal.
Sir, that's right. From the narration of the patient, we get the intensity of symptom. But sir, the patients are some also the reserved who are introverted, and from that patient we get difficult to know from about their life situations, their cravings. If a patient is loquacious, then he can say, हाँ मुझे मतलब अकेला रहना पसंद है, मुझे ज़्यादा लोगों से मिक्सअप पसंद नहीं है. So from that exaggeration of narration, हमको पता चलता है कि मतलब उसे अकेला रहना पसंद है. बट मतलब कोई शाय पेशेंट रहता है, रिजर्व होता है, तो उतना बोलता नहीं है. वो सिर्फ एक बार बोलेगा हाँ मुझे अकेला रहना पसंद नहीं, और वो अकेला ही रहेगा. तो फिर उसमें वो मतलब डिजायर टू बी अलोन की इंटेंसिटी तो फिर कैसे आइडेंटिफाई करना?
Ujjwal, don't go by how much patient is talking, because loquacious patient will take you on the ride, and you will not be able to understand. There are all different types of people. People speaks does not mean he is expressing. We have to understand. That is why what we require to have is sound senses. We should not be carried away with the patient. We should not be disturbed within. I have to register things as it is. So, patient's narration along with his facial expression and gestures, along with observers, all these three things will only help you to understand, not the words, not only the behavior and gesture. Everything together will help you to understand. So your question about patient is shy or reserved, that is following up in the next question. So we'll take up that at that time. Is that okay?
Okay, sir.
Okay, go ahead.
So
Here I am
another
reducing only to point that how to assess intensity. Now, how to assess intensity of the shy and reserved, that we'll see how to deal with the shy and reserved kind of people. Okay? Go ahead, yeah, please.
So another question which has been asked by Dr. Snehal Verma, how do we ascertain the intensity of patient in case of a hypochondriac patients?
Hmm. No, the answer is there in the question itself, isn't it? If you understand what is hypochondriasis, then you have to minus that hypochondriasis. That is why here the role of the physician comes up of his observation and attendant. This is something very, very important. That whether patient is exaggerating the thing or it is at actual, how the factual level, how the patient is suffering. Is this giving you answer?
Dr. Snehal, did you understand the answer given by sir? Yeah, she has understood it.
Thank you, Snehal.
So another question which is related to case taking in addicted patients.
So what is the problem? Patient is addicted individual. Whether he has come for the de-addiction or patient has come for the various other problems and is having addictions. So what is the situation? Can you just clarify the situation? Okay, how do you deal with the person who is addicted to tea, addicted to coffee, addicted to tobacco, and coming into your, or addicted to alcohol? They are coming into your, how do we approach? The way we approach to any other case, right? The point comes up when patient, because of the addiction, is having the change in his morality and intellectual character. Because of the addictions, certain substances. Person is going into hallucination, delusions, different perceptions, or because of the addictions, person has become a liar, person has started uh, uh, doing robbery, or what are criminal-minded things are occurring. So we have to understand the problem. And here in the such cases, in the substance addictions, relatives, observers are the best to give us the judgment. Because addicted people, why will they come or of their own to leave the addiction unless a person comes to the senses that, okay, I want to leave it. But that is very rare. Usually family members want him to leave it. So many times you don't know the internal situation of the patient, or person's internal situation is drastically changed because of the substance abuse. So we have to understand such things. Otherwise, in other type of the cases, addicted to various vices like tea, tobacco, coffee, or any other substances. So they are in their insanity. So you have to get the right picture. At the same time, you have to understand that what the tobacco has made a change in him. Person may say that after consuming tobacco after so long period of time, cramps have started coming up in the legs. Or person has started losing his sexual power. Or there may be change in his temperament. Memory is getting affected. Intellectual character is getting affected. All these things when they started coming up, then we have to understand these are the iatrogenic problems, toxicity. Rather than iatrogenic, the word is toxicity of that substance. That we can easily find out from the toxicity of the tobacco, toxicity of caffeine, toxicity of whatever is patient taking. So obviously this is becoming a complex disease. Some people at our one say they leave tobacco, alcohol, they are ready to bring change, but it may not be easy for all the patients. So from case to case we have to see that how will we help the patient, because we have a right medicine. I have seen in OPD many such cases that after giving the right medicine, now they don't need stimulants to that great extent or in that much quantity. So obviously, gradually things go on decreasing. Does that satisfy the questions?
Yes, sir.
Okay, thank you. We go ahead.
So the next question is case taking related, approaching reserve person. How do you manage a case taking in a reserve person?
Yeah, shy and reserved person, usual. Your situation is right here in front of us. Person is shy and reserved. So how to get the characteristics from the person? The first thing, right in front of us, I am getting through my observation that there is a shyness and reserved. So the basic fundamental quality of patient is right in front of me. Now the point is patient is suppose not opening up. So what is he shy about? Or what is making him reserved? Why he is not opening up? Some certain point of time, it is possible that you can, through your concern and through your positive approach, he may open up. The point is patient has to have the confidence in you that the matter is going to be confidential. You are not a threat. If you can make that, give that assurance to the patient, it is possible that patient will start opening up. Person remains shy or reserved. Why? Because person has developed that kind of defense mechanism and surviving. He finds it is better not to talk. If I talk, I may be misunderstood, or I may be reproached, or I may be criticized. There may be such experiences, sensitizations of the patient, which make person to remain so. So whatever person takes up as a shyness or reservedness, that may be mainly the system to survive at minimum cost. So usually people open up moment they feel assured that yes, you are the right person whom you can be confided. But if not, oh Jewel, then we have to go and follow what Dr. Boni Hussain has said. You remember Boni Hussain in his original preface of Therapeutic Pocketbook has written that in the construction of first chapter that is on mind, he has taken care that he has avoided all the secondary symptoms, but only the primary one are taken up. Because secondary symptoms are found in all the sections, but more in section of mind. So that is what is very important, that when we are approaching to understand mind of the patient, we should not get entangled in the story of the patient. We should not get carried away by the story of the patient. Patient's own defense, own ego, own various aspects of the life that come up because person is habituated to impress others. and you should not become a part of that or victim of that. So he said, whatever are the characteristic symptoms in the case, you take them and come to the group of the drugs. When you come to the group of the drugs, then you match it with the dispositional features and mind. Now you see patient is shy. Now when you see patient is shy, it means remedy has to have a curative power to shyness of the patient. So you don't give a remedy which has the curative power to have a boldness, or who is repulsive, or who is very aggressive. When you see that remedy has to be of this kind, now our job is to find out the different shyness, different kinds of the shyness, because every remedy has different kinds of the shyness. Through the observation, when person is shy or reserved, what is the facial expression? Is there very flushish? Is there, what is the position of the eyelids? You understand from these different aspects, and we find out if possible to differentiate shyness and reservedness, we do that. But so many times we are not trained that much, or things look alike. Then, out of the group of the remedies, which remedy is matching to the curability of shyness and reservedness? That is sufficient. You don't prescribe, as Dr. Hahnemann has written, you don't prescribe chamomilla in a quiet child. It is something like that. So we have to get best of whatever is there in front of us, and follow various guidelines given by the masters, because they have come across the same difficulties that we have come across, and they are guiding us, which we put by the name of the approaches. Okay? So Ujjwal, does that answer your question?
Yes, sir, understood. Sir,
Okay.
can you please tell about types of shyness that we can
Sorry?
find out with सर मतलब टाइप्स ऑफ शाइनेस कैसे आइडेंटिफाई करने का फ्रॉम ऑब्जर्वेशन लाइक आपने बोला एक
शाइनेस के लिए रूब्रिक क्या है? टिमिड.
यस
आप टिमिड में जाओ. अंडर टिमिड देयर आर नंबर ऑफ द ड्रग्स. ओपन एवरी रेमेडी and find out shyness or timidity in that. And then you go on mentioning expressions of timidity in various remedies. Baraita का shyness कैसा है? कैलकेरिया का shyness कैसा है? इग्निशिया का shyness कैसा है? पल्सेटिला का shyness कैसा है? All the narrations are given, and you will find the differences from the Materia Medica.
यस सर
Okay, thank you. We go
थैंक
ahead.
यू सर
Yeah.
So, so the next question is related to mental diseases. Case taking in a psychiatric patient, especially when we are dealing with schizophrenia.
Yes. So, how do we proceed ahead? Clear guideline has been given by Dr. Hahnemann. Corporeal disease, mental disease, mind to corporeal, corporeal to mind, psychosomatic, soma-psychotic, and mental disease, right? And corporeal disease. See, the schizophrenia is again organic changes taken place in the brain, mind. So that is why all these chemical changes are producing chemical locha. It is producing what? Hallucination, delusions, various aspects. Now the point, intellect is clouded. So patient may not be able to give the exact observations of himself, because you require that faculty. You require your intellectual assistance in understanding the symptoms, even emotions, because that gives the vocabulary and the expressive power. So the patients who are having the clouding and these faculties are affected, obviously what will help you more, we take benefit of the observers. An observer tell us before and after and can tell us about the deviation. Deviation is most essential because deviation will help us to understand the causation. And from deviation, we will be able to understand the morbid phenomenon. Now, the observations of the behavior of the patient before, during, after, and quiescent phase. All these phases are important to understand. Most important is quiescent phase, because in quiescent phase, pathology, the chemical loci is at its minimum. And we get maximum of the patient. Now, in mental case, mind is clouded, so what is easily available is physical, and we dare not talk to the schizophrenia about his delusions, that these are all fake things. We cannot talk all those things, but we can easily talk about physical symptoms. And so, physical concomitants are very important for mental disease. Likewise, mental concomitants are for physical problems. That gives us the holistic perception of the disease. So we take up physical definite symptoms, unquestionable symptoms, and out of that more so if they are concomitant, then they are to be considered. Number one. Number two is, don't neglect or reject your patient. You listen to them, their fancies, their delusions, and give weightage to that. Now, all the schizophrenia do not get all the delusions. Certain delusions may be found in the majority of the schizophrenia. But even then, group is not same in all the schizophrenia. So these delusions by itself can be the differentiating point. In the throat pain, there are so many patients who get stitching pain, so many gets burning pain, so many gets cutting pain. But even then they are class apart from each other, right? So likewise, schizophrenic having their own delusions or hallucinations. All the different people have a different experience of the condition of the disease. Now the point is, if patient comes in a very exacerbated phase, in such conditions, Hahnemann is given, first of all, you address the patient with certain drugs like belladonna, hyoscyamus, or stramonium. Why these three drugs are given as a name? Because they have a tendency. Now stramonium, you consume stramonium, dhatura poisoning, you consume it and you go into that kind of frenzy very immediately. The people who are having the toxicology of such kind, or hyoscyamus. So hyoscyamin by itself can produce the change. Atropine by itself can bring a change. So that is why these drugs come up in a very aggressive, violent, frenzy cases. But other cases, in such violent, aggressive cases, even veratrum can come up, or any remedy can come up if you can correlate them very well. But these are the experiences of Dr. Hahnemann, that these three drugs recalls very fast. And you can at least help him to settle down with the attack. Then you can have interaction with the patients. And you can take the case. I hope this is sufficient to explain the question.
Yes. I think, sir, it was well explained. And I think participants have also understood it.
The same situation occurs in the case of the depression. Those who are in very deep depression, life is very black, person is very gloomy, disappointed, hopeless, may not be able to narrate, but we have to observe and see and read and hear their tears, what they are conveying. And most important is, again, the deviation and the causation. Okay. So, Dr. Rakesh, what do you suggest? It is about 5:20. If people are interested, I can go on talking for hours together, but if they are interested, we continue. Otherwise, we can plan another session some other day.
So participants are going to decide.
So those who want us to continue, please respond immediately. Okay, Puneet says yes. How many are with Puneet? Because our interaction should not be exhaustive. Your concentration, your freshness is very essential. Thank you, Pankaj Bhai. Yes. So, Dr. Rakesh, you are the host. You have to decide.
So I think we can continue further for another 15-20 minutes.
Oh, great.
Because I think the tempo is built up and everybody is completely absorbed into the discussion.
Oh, great. Why not? I am loving it. Okay, go ahead.
So this is very interesting thing, and I think we often face this situation in our clinical practice. Approach for paucity of symptoms in mental diseases or paucity of mental symptoms.
When we take case, most of the time, get physical generals and particulars and with difficulty after asking somewhat direct questions of my mental health. Which approach should we really use? We have already discussed at a greater length, allow patient to talk. Give him time to express himself. Give him sufficient space. Don't be threat. Your facial expressions should be full of concern and care. Yes, I am with you. Barbara Bates. Hello. Read Barbara Bates. Case taking. And she has written beautifully that when you have to be empathetic, when you have to be sympathetic, when you have to show the concern to the patient, when you have to contradict to the patient. So all these things will support or stimulate the patient. It will encourage the patient. Very simple point she has written, and that is very helpful to me. I've always seen helping me. When patient is not going any further, shy, reserved people, or patient says cut to cut, said and finished. Repeat the last part of whatever patient has said. डॉक्टर मुझे इतनी भूख लगती है ना फिर I cannot tolerate. I have to eat. finish. Oh, आपको इतनी भूख लगती है कि you have to eat. हाँ डॉक्टर, चारा ही नहीं है, मैं नहीं खाता हूँ ना तो हेडेक होता है, चक्कर आता है, मुझे पसीना होने लगता है. ओके ओके, you get headache and पसीना also. Yes doctor, headache तो पूछो मत. See how the things go on. Are you with me? Hello?
Yes, sir.
This is what Dr. Barbara Bed says is a facilitating the patient. You are facilitator. You are encouraging the patient. And you are giving him direction. Yes, in this direction go ahead. Don't put direct question. Patient को पूछना नहीं कभी तुम्हारा स्वभाव कैसा है. You just see if somebody asks you how you are going to respond. कोई आप बोलने वाले मेरा स्वभाव बहुत बुरा है, आप बोलेंगे अच्छा है. So don't block yourself through your patient. Always be with the patient, be open, be fluid, be flowing, and see how patient goes ahead. Always remember one thing. Aphorism number 7. Disease will take you to the remedy. क्या beautiful sentence लिखा है. You don't fit any remedy on the patient. Free flowing. You be free flowing. Patient आपको लेके जाएगा. Doctor, this is my remedy because this is my problem. The moment you know the problem, you know the remedy. Is that very clear? There is a simple approach. Allow patient. Give space to the patient. Not only patient, in life, everywhere. Everything, if you want things to be easy, then give space to others. Don't be prejudiced. Have sound senses. Everybody wants to communicate, everybody wants to talk, and that is why person has come in, and that is why you have been paid. So patient is paying you to give a ear. ठीक है ना? Have patience, and patience will open up. Otherwise, your observation, patient's gestures, expression, everything we have done. And that is why, if you understand this, that is why this point has got a special place by Dr. Bogart when he is narrating in his foreword his approach. सबसे पहला aggravation, possession. Second, mind. Aggravation, possession, then aggravation, then mind. And last but not least is observations and position of the patient. Okay? Go ahead.
So next question is case taking, observations and their role in selection of remedy.
We have done
I think
that.
you have already answered that.
We have done that very beautifully, yes.
So now the next section for the question starts. There is a lot of confusion amongst the beginners. What is the difference between repertory versus the approach, repertorial approach? So sir, can you just guide us or throw some light on this?
Okay,
And,
so
yeah.
When you are going for, you were telling something, Dr.
Yeah, so the same thing, sir. Difference between repertory and the repertorial approach.
Okay, so now we are going about further processing of the case. At primary level, we have to understand what is most important is knowing the problem in its right perception. If we have not understood the problem with its right essence, then best of the repertory, best of the approaches, best of the mathematical knowledge, best of everything will not get us a result. Result is zero. Because we don't know what are we supposed to treat. How do we know what is the solution? Then it becomes like Victoria number 203. We have a key. Om Prakash and Mr. Ganguly, क्या नाम है उसका? Ashok Kumar. They had a key and they had to find a lock. We should not get trapped to that particular point. We have to have the lock. कि ये lock को unlock करना है. And we have to be very, very clear. If we are not clear at this level, please don't open repertory. Don't open any tool. We have a wrong habit. Moment patient says something, doctor मुझे अकेला लगता है, oh 4 seconds. We start turning the pages or put symptom in our gadget. Don't do that. What patient says, it may mean something else. क्या हम समझेंगे? पेशेंट सेज आई फील लोनली. We start understanding and interpreting. The patient is lonely, patient is deserted, patient is abandoned, patient has not been taken care of, patient is neglected, patient feel alone, patient is repudiated, or not, what not. But patient is telling, I feel lonely. The only successful man in the world. I see all others unsuccessful. Patient says something different, my dear. So don't make the point that I have understood. So don't open tools. Don't open repertory. Don't go to any approaches. Foremost thing is love your patient and help patient. Love for curing him. Huh? So you just help your patient to cure. So if we, with that understanding, if we are going into now this particular, now we are entering into dragon. We now see repertory versus approach. Repertory is nothing but a reproduction of materia medica in the index form. In the materia medica, drug having all the symptoms under its label. Whereas in repertory, all the drugs under the level of the symptom. It is same, it is materia medica, but produced in the different way. So repertory is a tool. Repertory is not anything else. Now, materia medica format is changed at time of making repertory, then it doesn't give a replica of materia medica. The curative power of the remedies are given in materia medica. Unless the repertory is of a pure form, Puritan type of repertory. Moment repertory is logico-utilitarian type of repertory, will have a change in its formats. Very important. Symptom from Allen's Encyclopedia. Remedy is Mercury. Symptom is Brewer has expressed guilt that he has committed crime. That is why he is sleepless and he wants to escape from the bed. Now this will make three rubrics, minimum three rubrics. Escape desire to, attempts to, Mercury. Religion criminal he is, Mercury. Restless, sleep during, Mercury. So quantitatively we will see Mercury. But qualitatively, the rubric is, the symptom is in this format. The dots are combined in this way. So quantitatively, we'll say, oh, Mercury is covering sleeplessness, restlessness during sleep, escape attempts to, and delusional ease. Oh, in all these three, Mercury is coming. Give Mercury. No. The combination is, he is feeling that he is criminal, as a result of which he wants to escape. He is unable to sleep because of this, he is restless. Are you getting my point? Repertory is only a mechanical tool. So don't ever thrive, don't ever depend on your analytical quantitative results. Approach gives you the process, the thinking behind how are you going to use the tool. Whatever you are doing with the tool depends upon your purpose, and according to the purpose, how are you applying the tool. So this is the difference. Approach gives you the basic fundamental understanding how are you going to use the tool. Is it clear? Your purpose, your way of doing it, that comes under approach. Knife is a tool. Your approach, how are you are using knife as a screwdriver with a different thinking. Your knife, you are defending yourself. With knife, you are murdering somebody. With knife, you are muskafying. Hello? So how you are using a tool is with what is your approach. How will you utilize it? What is your purpose? Your skill. Your skill will come on with approach. So does it reply to the question?
Yes, sir. I think it was quite explanatory and we have understood it. Any other doubt related to this?
How every person looks or understands the fundamentals of homeopathy, of law of similia, individualization, and holistic perception of disease. That will vary. How Kent will see, how Hahnemann will see, how Dr. Rakesh will see, how Dr. Yarish will see, how I will see, how Dr. Boger will see. That will depend upon our understanding, or how Dr. Hahnemann himself had seen and applied to find out the remedy. So that varies. Okay. And as per their hurdles, they have given the guidelines. And in this situation, if mind is not able, how will you go ahead? Or if mind is available, then if specific available or at the general level it is available. So that will come as a their guidelines in the different situations. I would suggest to read original preface of Dr. Boni Hussain, preface of Dr. Kent's articles, how use of repertory, how to study repertory, how to use repertory. Boger's forward. Then we will understand how they look at these three things. Application of law of similia, individualization and holistic perception of disease. बस ये तीन चीज में सारी बातें आ जाती है. Okay. This is, exploring and our doubts about case taking, collection of the data, going into the core, understanding disposition was a totally one aspect. Now we are going into another aspect in which it will have a lot of such similar questions. And what I suggest that this series about repertory and its application and rubrics and selection of remedy, all these questions, we can take up in the another webinar if it is suitable with the schedule of Satva.
Yeah, sir. We can go ahead with that.
Okay.
Yes.
So we will have some other day what the group says, because we are entering into the entirely a different perspective of application. We are translating case into a different manner. We are understanding that case from the different point. What we have not done, case taking and repertorization. What is required is the in-between phase. That was totality of symptom. And there is no question asked about totality of symptoms. The most essential part, why are we taking case? We are taking case to understand the problem and what is to be treated is reflected as a totality of symptom, because essence of the disease is totality of symptom. And we are not addressing to totality of symptom. From case taking symptoms, we go straight away to the repertorization. Most dangerous step. So please understand, read aphorism number 7, understand about totality of symptoms, read the cases which I have suggested you. Case number 1, Bone Sense, Therapeutic Pocket Book, original preface. 1 case has been given. 2 cases of Dr. Hahnemann himself in the lesser writing or Mathematica Pura preamble. 2 cases of Dr. Hahnemann. He has given beautifully how will you make totality. Then herring scaling symptom. Open any drug. Open any section. There are 48 sections in every drug. Open up any, specially read about fevers. Beautifully you will find how he has presented one case of fever after another. So that is the totality. Once we are well versed with totality, you can play with repertory, no problem. I love talking to you, and I hope this was helpful to you. Together, we can definitely grow and have a fellowship so that we are at the same page and we can grow and have the results of the same kind. And nothing is theoretical from whatever we have taught. Dr. Yarish, aren't we applying this in our practice every day? Yes. Because we have no other choice. And you also put that into the practice. Very simple steps. And it will unlock. This is Hahnemannian key to unlock all the locked things. Okay? So thank you, Dr. Rakesh, giving me opportunity being with my most people who I love them, and I interacted. I really felt healed. I feel repaired after talking to your people, and hope to see you again.
So it's an honor for Satva to have you.
Small point I just tell. We are having a Saturday homeopathic study circle. Alternate Saturdays, we meet together, interns, students, junior doctors, senior doctors, we all come together and we discuss cases, experiences, how to study, how to approach. And this was started by interns and students because when I was leaving college, they felt to remain connected with me. So we planned to have these sessions. And this is done by interns. And now Homeopathy Forever charity is giving us support for all technical aspects. Dr. Pankaj Bhai Lakhani is doing it. You all have my telephone number. Some of you are already part of the group. My telephone number is 98. You may write down. My telephone number is 9833150025. I repeat, 9833150025. You can send your willingness to join that Saturday group, and Dr. Pankaj Bhai Lakhani will do the needful. Or you can contact Dr. Yarish Sadri, and he will connect you with me, and he will connect you to the group. It is every alternate Saturday at night, 9:30 to 11 o'clock. And we have so many times speakers from different part of the world, and we always have one guest who also shares his experiences. And of course, I get opportunity to facilitate the group. So I don't leave the opportunity, and I act as a facilitator at the end. But this is one platform, just like what Dr. Rakesh is doing. You can also join and be part of the fellowship program. Thank you very much, Dr. Rakesh.
Thank you, sir. So it's a pleasure and honor for Satva to have you, and you have never left. You're always there in our heart, sir. We miss you a lot, and I remember that small teachings and preachings which you had suggested during my growing up days, and today I'm actually able to implement it, especially in IPD. So it's an honor to always work with you, and Satva would be glad to join hands with you and continue to do certain programs and webinars and seminars and workshops. So thanks a lot, sir. So I would like Dr.
Anytime and every time.
Yes, sir.
Now we have taken up one task. I just take a few moments. We have taken up some task whereby since all the students are not aware about our activities and they can't join, we have started visiting various colleges. Recently, we visited 7 colleges in Gujarat, 3 colleges at Mehsana, 1 at Ahmedabad, 1 at Keem, 1 at Baroda. So we go to various university colleges, and here we address to interns, 3rd year and 4th year students about Hahnemannian Fundamentals, and we express through discussion, interaction, and case presentation to motivate them. And this has given us a very encouraging response that many came forward and said we were to do GP practice, but now after learning, because we never understood Hahnemann in this particular manner, and we think that we can put into the action, and we are now interested in homeopathic practice. That if homeopathy, there is one YouTube channel, Homeopathy Super Fast by Dr. Pankaj Lakhani. You can visit that, and this really impressed and encouraged students that yes, homeopathy can also give results so fast and so beautifully. So why not to take it up, because that is homeopathic practice is more profitable than any other. Because investment, medicine cost and everything is different. So anyways, This is our job. We are doing it, and many more people are getting connected with us. So our next target is again Rajkot, Bhavnagar colleges. So about 10 colleges we are planning to address in September. That is a part of our task and job, that whatever little bit we can return to homeopathy. It is not so much important how much homeopathy has given to us. It is also important that what we can give back to homeopathy. So please support us and help us in whatever best way you can, through your connection, through your contacts, like Dr. Punit Rana. He helped me a lot at Mehsana. So the story goes on, and we will someday we will make a history that yes, हमने भी homeopathy में कुछ दिया है. Okay. Thank you, Dr. Rakesh. You are doing a lot of good work.
I wish I could meet all of you together. It is really a noble thing, sir. Generating a second line is what we give back to our profession, because everybody lives for oneself. But if you can generate and strengthen the youngsters, there is nothing like it. So I'm really impressed and glad to know this side of the group. I would definitely meet up all of you one
We
day.
will do that because
Yes.
institutions can only come up. Yesterday we were having a chief guest of honor, Dr. Vipul Sastry. He is a dean of Vidyadeep University at Kim, and he invited us to structure courses, university courses, like the way we have in MUHS fellowship courses and other courses. But he said to make more meaningful structure courses where we can help students to see their career through homeopathy. So efficiency-based courses now, we are just planning to make it. And those who are academicians and people like you who have experience, and those who are novice or beginners, they can also send us the suggestion that include such things in the course so that it will be really helpful and ready to use. So time is coming up.
Thank you, sir, for everything. I would now like Dr. Yarish Sadri to address with a vote of thanks.
Thank you, Dr. Kamlesh, sir. Thank you so much for solving the queries of the younger generation of practitioners. I must say that because of this, many of us would be more confident in our practice. Thank you so much once again for the enlightening session. I would like to thank Satva Charitable Sanstha for giving this platform to nurture and help budding homeopaths by giving them a new direction. And lastly, I would like to thank the audience for being patient listeners. Hope you all enjoyed this session. We'll be carrying this session forward in the upcoming weeks. Thank you and have a lovely evening.
Thank you, sir.
My pleasure, dear. Okay. For now, bye to all.
Thank you, everyone. Thank you.